Hello there, good afternoon. My name is Aria. I'm just going to go through a few kit that we use for epistaxis, nosebleeds, how to manage it. We're just going to go through the equipment that we usually use. It's good to have and be familiar with the names of them and how to use them. First and foremost, if you've got someone with epistaxis or a nosebleed, it's quite important that knowing that you always start with your ABCD, make sure you've got your own protective equipment because patients tend to cough, you might get blood in your eye or your mouth, so always wear a shield. Make sure you've got a, if you can wear an apron better, your gloves on, and obviously it's a genital procedure, so just follow the COVID protocol where you practice. So this is my colleague Tom. Hello Tom. So suppose Tom is having a nosebleed. Things that are important before we start thinking about managing someone's nosebleed, so hopefully stopping it, is going through your ABCD, so making sure the patient is safe. So it's always good to practice, especially when you're stopping nosebleeds, that you've got someone else to be able to help you. It makes the job a lot easier. It's a lot safer for the patient as well. And don't forget that most people who've got nosebleeds, they tend to be older, and they need you need to talk to them, reassure them, tell them what you're doing. Don't forget they're frightened. And nosebleeds, it's bleeding near your oropharynx and your airway, so it can be quite frightening. So your communication with the patient is also quite important. Right. Let's say Tom has come to us, he's having a nosebleed. You can ask your colleague to do a set of observations for you. It's quite important as you go through your ABCD, so you've done your observations that the oxygen saturation is alright, they're breathing okay. Presume they're bleeding profusely. You can always start with a good old kidney dish. You give that to them. Actually, a patient can help you in several ways when you're trying to manage their nosebleed. Once they've got this, you encourage them to bring their chin forward, as Tom is showing you, and encourage them to spit out rather than swallow, because as you know, blood into the stomach means the patient gets sick and they're not moist. The other thing that you can do whilst you're setting things up, again, you can ask the patient to, Tom, could you pinch your nose at the bottom, squeeze your part of your nose, and hold that tight. Make sure that the elbow is on somewhere that they can rest it, so they don't get tired whilst they do that. And that usually stops the anterior epistaxis whilst you're getting stuff ready. Okay, that's fine, thank you. It's good before you start doing anything that you've got a cannula inside you. Whilst you're doing that, take blood, so you want full blood count. Always check liver function, just in case there's any underlying bleeding problems. Coagulation you want to check, and group and save. Again, in case down the line you need to do something. This is a bag. Essentially, what these bags are, they're quite helpful. They're ice packs, so you squeeze them to activate them, and you tend to put it at the back of the patient's neck as such, and you can put one in front. And essentially, as you drop the temperature, the vasoconstricts might allow a bit of time to get yourself ready. Another thing that you need is a very good headlight. Again, for you to be able to stop the nosebleeds, the equipment is essentially most of the work. If you've got a complete equipment, you're more likely to be able to stop the bleeds. I usually carry my own headlights. It's a bit easier, especially when you go to A&E. So make sure it's got a good old illumination, so you can see where it's coming from. Okay. What I usually do is once I've got my protective equipment, I get my light on. I introduce myself. Hi Tom, my name is Ari, I'm the ear, nose and throat doctor. I'm really sorry that you had to come with a nosebleed today. We're going to do our best to stop your nosebleeds. We're not going to hopefully do anything to make you uncomfortable, but I will take you through the parts that might be not as comfortable as it should. Okay. Right. Whilst let's say we've done our ABC. Now, just want to assess the patient. I usually start with a tongue depressor. So this is a Lux tongue depressor. Much better than the wooden one because it's a bit more rigid, allows you a bit more pass, so you can have a look at the back of the throat. Then usually I start by looking at the back of the mouth. I'll ask the tongue to open his mouth, and then we'll push down and have a good look at the back of the oropharynx. What you're looking at, essentially posterior to the posterior pillar of the tonsil, you look at for streaks of blood, whether it's actively bleeding, not bleeding, or there's a clot out there that needs to come out. If there's a clot at the back, you can try to suction it out. Again, it's a little bit uncomfortable if you start with that because you might suction the uvula in and it might make them gag, so it's not terribly comfortable. So I usually do that at the end. The next thing you want to do is actually look inside each side of the nostril. Again, what do? I usually try to use my thumb rather than a thoracic first to have a global look. Once you let go of the bottom of the nose, you look at left and right, see where there's a stream, so that usually means that's the site of you bleeding. And then you lift the tip of the nose and you have a good look inside, and what you're assessing, you're trying to see where the blood is coming from. As you know, it's, most of the time it's coming from the septum, so that's the place that you want to look at. The next thing that I do, I usually decongest the nose. So I use, or most places they use phenylephrine with a bit of lidocaine, so you'll, of course in some vasoconstriction you numb the nose as well. So it's quite helpful. Even if you've got a profuse bleeding, it's quite a good idea to use this. So essentially mount your the plastic tip end on, and you apply it right to the back of the nose. Yes, most of it might come out because they're actively bleeding, but still you've got to get some local anaesthetic effect. So again, if you're going to pack them later with something like a nasal it's a lot more comfortable. And I will decongest both sides. And every time that you do something to the patient's nose, you can ask the patient or Tom, could you please squish the bottom of your nose? So again, it just allows you to go back and forth between your trolley here. So if you now guys have a look at this, I'm just going to tell you the name of these equipments. I'm sure you know, but it's just to remind ourselves what they are. So this is my tongue depressor. This is a Lux. This is a Fodicum. Again, it's a nasal speculum. Again, it's quite important. And another thing that we use a lot is a Tilly's forceps, and I will show you how it looks like. This will allow you to use to apply cotton wool soaked patties, especially to the septum. Because you've got an anterior bleed, it's good to reduce the flow. It just gives you more ability to see what you're doing. Give you what it looks like, and you know how to hold it. So you hold it like that. Ice Pipe talks about this stuff called Nasopol. They're made by Stryker, and they're absorbable packs. Essentially, it's a sponge that you can use and fashion how you want to use it. The septum cream, I usually have some adrenaline at hand in my pack. Again, it's a much better vasoconstrictor than phenylephrine, and it gives a good result if you use it as a patties. Silver nitrate sticks for, again, if you've got an anterior bleed or you see a specific point that you want to cauterize. Aquagel. I use Aquagel, let's say you've had somebody who's been inside the hospital for a couple of days, they had a rapid rhino in the nose. Usually the front of the nose gets quite crusty and dry. It's good to start with a bit of Aquagel around the front of the nose to just soften things up so when you're taking it out, it's a bit more comfortable for the patient. This is called a Maricel. Maricel, I think it's usually used less. It's used more in elective settings. If somebody's had a septoplasty and the surgeon just wants to make sure that everything is nice and dry, at the end they put one of these in. Essentially it's a tampon. So this is placed in and then you inflate it by absorbing some saline, so you just inject some sodium chloride to it. Other things that you need are, let's say your anterior cautery wasn't successful and the patient's bleeding and you just need to use another system to stop the bleed. One thing that is used a lot these days is a rapid rhino. So we've got 3 of them here, and there are 3 different sizes. So these 2 are single lumen one. One is longer than the other. So if you look at the back, there's a 5.5 centimeters and it says anterior. And this one is a 7.5 centimeter and it says anterior posterior. So you've got a bit of a coverage of your nasal cavity. The important thing is that usually these 2 go past the crista ethmoidalis, so essentially just anterior to the SPA artery. So they're helpful. Let's say somebody's still bleeding and the bleeding is further back, and then you can use one of these ones. These are double lumen, and as you can see, one has got a wing with a green line over it, and that's usually a balloon towards the end of the pack, which is here. So you block the posterior nasal space to block it with this, and it's usually I go to maximum 6 millimeters of water. Don't use air. What I mean is you go back to about 6 mils of air, and then you inflate it, and then you inflate the front one. Again, up to 7 usually. All right. If you're packing one side, you can increase the pressure up to 12 on these 2. Same as this one anterior. If you've packed both sides, you've got to split the amount of pressure, otherwise you will get septal necrosis. You don't want that. Other things that, again, you might have seen around your unit is one of these stuff. It's something called a flow seal. It works very well. It's a hemostat that essentially you need to construct a sort of different. There's a calcium powder in there. You've got to dissolve it, and you've got to activate the clotting factors in there, and then you place this in the nose. It's a semi-solid. I usually combine it with the nasal pour if you want to stop the bleeding. And these are, again, let's say somebody's got a deviated septum to the right or left, and you've tried all of this stuff and you just can't get to the back of the nose. The last resource is to use one of these. So this is a Foley catheter. What you do, you pass this through the nose in the front. You keep looking to the back of the mouth. As soon as you see the tip going down next to the uvula, I usually retract it back up a bit, and you inflate it about 3 to 4. Keep pulling back until you engage the posterior nasal space. And once you feel resistance, then you can blow it up to 7 mils. Then your assistants have to keep pulling at the front, so it doesn't go backwards, so it doesn't herniate. And then you pack anything anterior to that with this stuff called BIP. Essentially, it's a ribbon which is soaked in this material called BIP. It stands for bismuth iodoform paraffin paste. And the idea is that they can stay there for a while because they don't get infected because of the iodine on them, so they're quite useful. And once you've done that, you use an umbilical cord clamp to stop it going backwards. So for that, you need some gauze to place it between the clamp and the nose, otherwise you're going to get some necrosis. So, but we can show you how to do that later. Fine. Another thing which is quite important to have, and it's here so I can show you, you need essentially some cotton wool. It helps you quite a lot because it retains the fluid in either adrenal or phenylephrine, and you can place this on a septum, apply a bit of pressure, wait for a few minutes, and causes a basic constriction of over the little area, so you can see a little bit better. The way I use it is I break a little bit off, and then you put some of your either caffeine cream or adrenaline solution on it. Obviously, I'll be wearing full PPE and gloves, but this is just to show you. Once you've done that, just squeeze it a little bit, so I'm just trying not to waste any. And once you're making these patties, it's quite important to press them down. What you want is for them to be flat, so almost like this, and with a broad area, and that goes and sits on your septum, like so. And what you can do next, obviously, you place it with Tilly's forceps. Make sure that when you're using a Tilly's forceps, you don't touch the nasal mucosa, it can be quite sore. And then you use your Thudicum speculum so you can see a little bit better. If you find using your Thudicum a bit difficult, you can just use your thumb to lift the nasal tip so you can see where you're going to place it. Right. And these are, you only use them once, you dispose them. So when you see a 2 with a line across, it means that these are single use, they're not reusable, so you've got to throw it away. So if you've got something that doesn't have that, these can be used, but you need to have to clean it and so forth. This is the way how you hold the Thudicum. Again, I'm sure if you ask someone to be able to show you. It's between your 4th finger and your 3rd finger, and you push to close and you relax to open. Tom, would you like me to demonstrate this? Again, make sure you've got gloves on. I'm not going to put this in, I'm just going to show you that. You just make sure you don't cause too much trauma. When you open it a little bit, you can twist it, and then I can see septum, so then you can place this in and then just leave it there. Great. So that's how to play a bit of patties. You put the adrenaline the exact same way, so you can do that. So use this. Fine. Now, what I would like you to show you is to how to put a epistaxis in. Let's say you've tried all of these things, they're still bleeding, and you need to apply pressure a little bit more permanently to stop the bleed. I'm going to use, we usually use a 7.5, but it's depending where the bleeding is. Again, warn the patient what you're doing. It's very important that they trust you, because these things are quite long and they're quite painful to place. So, because they're very long and they go straight back. So you open this up, and this is the stuff. Then you pull the sheath out, and this is what it looks like. The cloth that you see over it, it's got some pregnated lubricating jelly, which when it contacts the moisture, it will sort of activates. As you can see, this is at the moment it's quite thin. Instead of using sodium chloride, which you can use, I tend to use a bit of aqua gel. With the aqua gel, the lubrication doesn't penetrate into the gauze over it, so it means that it doesn't swell up as much, i.e. it's thinner, so it's easier for the patient to go in, so it hurts less. Another thing that you need, obviously, to deploy this is a syringe, because that's how you inflate it. Make sure the patient's cavity is, you put several squirts of this, so it's completely numb, as numb as it can be, before putting this in. As I say, I warn them that this is going to hurt, and it really does hurt. And other important point is, when you admit them, they need to have lots of analgesics, lots of pain relief. Be nice to patients. Right, I'm not going to demonstrate on my colleague Tom, because I quite like him, and it's not very comfortable. So there is a model here, which I will ask Tom to hold. Right, so once you've warned the patient, you've put some jelly on this, and you've got this at hand. Usually we draw air to what you want to, I usually start with 7 mils of air to essentially place there and inflate it. Again, if you've got a assistant, get them to help you, and use suction to essentially remove any clots that you have. My suction fell on the floor. I tend to use a pediatric Yanker sucker. If you look at the tip of it, it doesn't have any side ports, so it suctions quite well compared to the adult Yanker sucker. If you look at the adult Yanker sucker, you'll see several pores, and that makes them not very good as cleaning nasal cavity. Because you've got a lot of side ports, and it kind of starts to suck at the inferior turbinate, and it becomes quite uncomfortable. Obviously, you've got the hole here, so you can have a gentle suck without obstructing that. Because you've got two holes sucking. If you want to increase your suction, you just block that, and then you get more suction power at the end, so you can suction a bit more. You can use a Zollner sucker, so these are the metallic suckers, which are a lot thinner. But with those ones, again, you just need to have a better control, and if you suck the mucosa, again, it'll be quite sore, and actually they do more damage than good. Great. So let's say I'll put my lubricating jelly on this, and I'm just going to place this in the nose. And what I usually do, I'll make sure that the patient is warned, that they've got something behind their head. So if you're in an ED trolley, make sure it's right at the back to the 90 angle, because as you go in, they will extend their neck because they want to run away from you because it's not very nice. And I've got this at hand, you warn them. I usually, let's say you've got the right side epistaxis, I lift the tip of the nose and move the slightly to myself so I can see. And again, the important thing is that nasal cavity goes backwards, so what you want to aim for is the earlobe. You can't go up because you can't. You can't go downwards, that's the floor, so you want to go backwards, backwards towards the earlobe. And actually, if you can see on this model, this is the nostril here, and the nasal cavity goes backwards, as you can see here. So entry through there, go backwards. If you go up, you go into the skull base, so you don't want to do that, and it won't fit, and it's sore. And you don't want to go lateral, go to the maxillary sinus opening, and again, you don't want to go that way because you go into the septum. And the way you place it, you warn the patient, you lift the tip, as we said, you place this inside, and as you can see my hands, you want to go hold it as such, and then you just push it backwards. So again, it will go backwards and sits like that. Again, when you place it in the patient, it's a lot easier than a model like that. So once it sits like this, you inflate it, and it will apply pressure. So hopefully, it will apply pressure where it needs to. I had 7 mils here, and then what you do is keep hold of the bottom so it doesn't come out as you apply pressure, because you want to deploy it inside, and then you just press it, and then it kind of stays in like that. So that's got about 7 mils in it, and it sits like this. Give it a few moments, give it 3-4 minutes. If it's still bleeding, just wait. Sometimes it just needs a bit of time. If it's still bleeding, put another 3 mils in there. So, and don't forget, as you apply this, it will start to come backwards, so the air will come out. So you just need to make sure that you've got a control of your plunger at the back. And then you put another 3, so you go up to 10. If they're still bleeding, you can keep increasing it. If you apply it correctly, and this is inflated to 12, you shouldn't get any anterior bleed. You might get a posterior bleed because it's not deployed in posterior nasal space and it's not long enough, but anterior you shouldn't get anything. Again, if they're bleeding still through anteriorly, you can just pack the front with a dip, and then you give it another 10-15 minutes, see whether it will eventually stay. Alright, I'm just going to take this out. And it's the same principle with the rest of the with the large rapid grinder. You apply it the same, it's just longer, so you just got to apply a bit more pressure. And these ones are longer, and they've got more, they apply more pressure to stop the bleeding, but they do bleed. They do hurt. Sorry, but they will stop you bleeding. Great. One thing about naseptin, so it's usually a cream you give to patients. Let's say you've done nasal cautery, you give them this naseptin cream. Traditionally, you ask people whether they're allergic to peanuts, because it contains peanut oil. If they are, so obviously avoid it. The alternative is Bactroban. which is essentially chlorhexidine paste, so you can use that instead. And it's good because it keeps the nasal mucosa moist and it will stop any infection. Very good. I hope it was helpful. We will make a bit more, a few more videos about how to deal with the nosebleed, so we can show you the other systems and how to do anterior cauteries and so forth. Yeah, hopefully it was useful. Thanks very much. Thank you.